Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. So welcome everyone to today's program, Prostate Cancer and Treatment Options. I'm Katie Armsby. I'm the Program Outreach Director with Cancer Support Community Atlanta. Just wanted to let you know Cancer Support Community Atlanta has a wide variety of both virtual and in-person programs, which do include support groups led by licensed mental health professionals. And I do want to highlight, we do have a prostate cancer support group that meets. I'm going to go ahead and put that flyer into today's program chat box so you can see all the details on how to connect to that program. We also have a caregiver or family and friends support group that meets as well. And both of those are led by licensed mental health professionals. We do have other programs like stress reduction classes. We have yoga, Tai Chi, cooking demonstration, kitchen, if you want to come watch a fun cooking demo, and then some art classes as well. So I'm going to put our website, CSC Atlanta, into the program chat box again, if you want to connect to any of those. And if you know anybody who missed a live recording of any event, you can find the recordings on our website as well, which will include today's program too. So I'm excited to welcome Dr. Ahmed Ali back to this virtual platform. Dr. Ahmed Ali completed his residency in radiation oncology at the University of Pennsylvania, where he also treated patients using proton therapy. Dr. Ali received additional training in the treatment of prostate cancer during the fellowship he was awarded through American Brachytherapy Society at the Seattle Prostate Institute. He has been practicing for 12 years and has been with Northside Radiation Oncology Consultants at Northside Hospital Cancer Institute Radiation Oncology in Midtown for 5 years. Dr. Ali specializes in the treatment of prostate cancer, including brachytherapy, prostate seed implantation, and external beam radiation therapy. So with that, welcome back, Dr. Ali, and I will pass it off to you to get things started.
Thank you for that wonderful introduction, Katie. Welcome, everybody. It's a joy to be here with you. I'm very excited about this presentation that we're about to dive into. I think it's a very thorough soup to nuts background about prostate cancer and its treatment options. So without further ado, we'll go ahead and get started. So this is the general roadmap. We'll give a little background about prostate cancer, talk about treatment options, get into some of the details about radiation therapy as well as rectal spacing, and then finish off with some next steps. So to start off with, before we talk about prostate cancer, let's talk about what is the prostate. So the prostate is a walnut-sized gland right below the bladder in front of the rectum. Anatomy is really important in terms of what we do, in terms of treatment and side effects. To really be able to understand the side effects, it's important to get some background with regards to the anatomy. This is a really nice view, this cross-section that we're looking at here, which shows the prostate sitting below the bladder and in front of the rectum. As you can see, the rectum is juxtaposed to the prostate right behind it. One other thing that I think is really valuable to that this view really provides a good visual for is how the urethra drains the bladder. So it's draining the bladder of urine and it's flowing right through the middle of the prostate into the penis and out of the penis. So that's the path of your urine. It's basically going to be aggregated and held in the bladder, and it's going to go through the urethra, which actually before it gets into the penis, it goes right through the middle of the prostate. The other function of the prostate is to supply and transport semen. So it's kind of at a cross section of a lot of functions in terms of urinary function, fertility function, and it's right next to the rectum, at least the back part of the prostate. One thing to note is a condition called benign prostatic hypertrophy, commonly known as an enlarged prostate gland. Again, the terminology is benign prostate hypertrophy. And so it truly is true and unrelated in most cases with men. It's a common process that just occurs as a function of aging. The prostate gets bigger, and in the vast majority of cases has nothing to do with prostate cancer. Prostate cancer can occur in the setting of BPH, but it oftentimes is not. And the symptoms of BPH can include a weaker urinary flow, difficulty starting and stopping urination, and a slightly increased PSA level, which can be all benign. So talking a little epidemiology, prostate cancer is the most common non-skin cancer in men. So it's very common. 1 in 8 men will have it. The good news is that the 5-year survival rates are really high, 98% in the modern era. And, if you look at those 2 boxes on the right, this kind of exemplifies what we're just talking about. For localized prostate cancer, the rates are even higher, 99 and greater percent survival rates at 5 years. So risk factors include age, genetics, race and ethnicity, and behaviors and lifestyle. So prostate cancer really starts to go up in men after the age of 50. Half of cases are actually found in men over 65. Most cases actually occur in men without any family history or genetic background with or of prostate cancer, but having family members with prostate cancer can more than double the risk. Black men are 1.7 times more likely to be diagnosed with prostate cancer than other men. And Latin and Hispanic men are 21% less likely to receive treatment. There are some behavior and lifestyle issues to bring to notice. Prostatitis, meaning chronic prostate inflammation, as well as sexually transmitted diseases, can potentially increase risk as well. So in the modern era, which we call the PSA era, most prostate cancers are discovered as a result of screening. And screening for men generally starts at the age of 50. For Black men or men with any family history, that drops down to 45 years of age. And for men that have additional risk factors, including multiple relatives that have that diagnosis, it further drops down to the age of 40. So the 2 most common ways we screen for prostate cancer, as we mentioned, is a serum test called a PSA. It's a blood test, and digital rectal exams when you see your doctor. Additional testing can be done if these tests are found to be normal, which include ultrasound or MRI, as well as patients with family history getting genetic testing. So a prostate biopsy is the gold standard in terms of diagnosing patients with prostate cancer. There may be irregularities on exam. There may be some abnormalities on MRI or other scans, but without a biopsy, patients do not have cancer. And that's usually done using ultrasound guidance, where patients go to a urologist and have a number of samples taken from their prostate that are analyzed to see if there's cancer in them. In terms of staging for prostate cancer, we use a staging criteria called TNM staging, which is an acronym, which we'll get into in just a minute. The other very important piece of information that we look at is the Gleason score, which we'll also get into in just a minute. So talking about the TNM cancer staging, T stands for tumor, and that basically looks at what the cancer size is within the tumor and if it's extending beyond the tumor, directly spreading. N stands for lymph nodes, and that basically designates if there are lymph nodes involved, how many and where. And M stands for metastases, meaning cancer that spread beyond the tumor itself, beyond the lymph nodes to other areas, such as, for example, the bones. Now, the Gleason score factors in terms of giving us an idea of what risk patients are: low risk, intermediate risk, or high risk. And that's determined by the pathologist when they actually look at the biopsy specimens or the prostatectomy specimen under the microscope. And it's categorized into 3 groups: low risk, intermediate risk, and high risk, based upon a number that is assigned to each slide or the patient's cells. And the numbers range between 6 and 10. 6 is considered low, 7 is considered intermediate, and anything 8 to 10 is considered high. And that number designation is given based upon how abnormal the cells look under the microscope. If they look slightly abnormal, for example, the pathologist will assign a score of perhaps 6. If they look a lot more different than a normal cell, they might get somewhere between 8 and 10. All right, so let's get into treatment options. So the most common treatment options are active surveillance, meaning watching the cancers slowly, using PSAs and perhaps biopsies and imaging. Secondarily, surgery, and lastly, radiation therapy. Other treatment options that we'll briefly touch on later are hormone therapy, chemotherapy, cryotherapy, high intensity ultrasound, immunotherapy, and targeted therapy. So active surveillance is really reserved for patients that either have a short life expectancy or patients that have a very low risk prostate cancer. And that's basically done with a certain surveillance regimen that includes PSA tests at interval frequencies, as well as digital rectal exams and imaging. Surgery, at least for prostate cancer, is called radical prostatectomy. It used to be that we used to do these procedures open, but with modern technology and surgical approaches evolving, most of these cases, at least at this present time, have kind of evolved to be done laparoscopically, oftentimes using the robot for assistance, robotic assistance. This does require general anesthesia, an overnight stay, and it is invasive. In terms of side effects, unlike active surveillance, which had no side effects, obviously you're not doing any kind of intervention. This can potentially have risk of having urinary incontinence, meaning leakage, erectile dysfunction, as well as loss of fertility. Radiation therapy, the first form of radiation therapy is external beam radiotherapy. And in terms of what it is, it's basically using X-rays that are highly targeted and can kill cancer cells. And it's non-invasive, and it does not require an overnight stay. It does not require any anesthesia. You lay on a table and get treated using X-rays. So patients really don't feel anything and don't see any light. It's done daily, 5 days a week, for the order of at least about 6 weeks. Well, 5.5 weeks to 8 weeks, generally speaking. And usually takes about 5 minutes a day in terms of the actual delivery, but patients in and out the door are usually in the department for about 20 minutes each day. Urinary incontinence, leakage, is not a side effect of radiation, but it can contribute to erectile dysfunction and can cause some rectal irritation or rectal bother. The other form of radiation is called brachytherapy. This means therapy that's given directly to the cancer using a minimally invasive procedure in which radiation is being given using a radioactive source that gives the cancer from the inside out. And what I mean about that is it usually is a procedure that is done under either local anesthesia or with moderate sedation or general anesthesia. It does not require an overnight stay, but it is minimally invasive. And it's used as monotherapy, meaning the only therapy needed for cure for patients with low risk prostate cancer, but it's also used in conjunction with external beam radiation for patients that have higher risk prostate cancers. And we can talk about that a little later. Oh, and in terms of side effects, similar to external beam radiation, it is not associated with urinary incontinence or leakage, but can contribute to sexual dysfunction to some degree, and can cause a little irritation, potentially low risk, but can potentially cause some irritation to the rectum. So this is a nice diagram of some of the different ways radiation can be offered to patients. On the left, we have external beam radiation, and on the right, we have the direct radiation called brachytherapy. Most patients these days are being treated using an intensity modulated radiotherapy approach. We've kind of evolved away from using a 3D conformal approach. Most centers are offering image-guided radiation therapy, where patients are able to be positioned accurately every day using CAT scans. Some patients are candidates for stereotactic body radiotherapy, which basically gives very high doses that are highly targeted in a lesser number of treatments. And proton therapy is another form of radiation. It uses a different type of ray, not X-rays, but a ray that has both charge and mass, and it has different properties. And looking at the right side, brachytherapy, there's two forms of brachytherapy. One is low dose rate brachytherapy, LDR, which otherwise is known as seed implants. Those implants are permanent and are left in the patient. The patient remain radioactive for about a year after the implant. Those are titanium shells. And a more modern way of delivering brachytherapy that may be maybe associated with lesser side effects is called high dose rate brachytherapy, which is delivered right at the time of the procedure, and patients therefore do not walk out with any radioactivity in their body. They're not radioactive after the radiation is delivered during the procedure. And we can talk about some of these options downstream. Okay, well, let's talk about a product that has helped radiation therapy called hydrogel, hydrogel rectal spacer. So we're circling back to our brief lesson in anatomy in terms of how closely and intimately the rectum is associated with the prostate. So we treat the entire prostate, and because we treat the entire prostate, including that backside that's touching up against the front part of the rectum, some of that rectum gets exposure to radiation, and that can cause irritation. And you can see this really nicely in this visual on the right side. The axial scan, the cross section at the top, has the kind of higher dose in red and orange, and then as the dose cools off, it becomes green and then blue. And as you can see behind the prostate, there's the area that's designated as the rectum. Some of that green and blue is spilling back into that area. on the top slide, and on the bottom, this is kind of a side profile of the same thing. And you can see some of that green and blue is kind of spilling back into that front part of the rectum, and that can cause a little bit of irritation and maybe create a little rectal urgency, which in translation, in terms of how it manifests in patients' daily lives, it can make patients feel like they're having to have a bowel movement, but they don't actually have to have a bowel movement. It just gives them a sense of pressure and urgency. And so we'll come back to this in just one moment. There's the rectal spacer product, the hydrogel rectal spacer product, since we're on the topic of anatomy, basically is placed behind the prostate, but in front of the rectum. And it basically pushes the rectum back and out of the way of the high dose radiation field. And the high dose radiation field in this picture over here to the right is designated by this dotted line. And so as you can see, that high dose rate with the rectal spacer in place is now kind of going into the spacer instead of affecting what would have been the rectum if that spacer wasn't there to push it back. And we'll come back to this slide to talk a little bit more about what the spacer is in just a moment. So this was actually looked at in a large randomized trial, which showed improved both GI and urinary side effects associated with the spacer placement, decrease in rectal toxicity and side effects from 6% without to 1% with, and urinary side effects from 32% without to 15% with. And so what is the spacer composed of? It's actually composed of polyethylene glycol, which has been used for decades and other medical implants safely. It's an inert substance. It basically stays in place for about 3 months before your body starts resorbing it. And by about 6 months, it's completely gone. So once it's done its job, it is absorbed by your body and does not need to be taken out. It just disappears. And so as we talked about, it has shown to be helpful with lesser bowel complications, improved urinary complications, and we're learning more and more about potentially better sexual outcomes. So next steps, it's important to know your risk level. We talked about some of those Gleason scores: low risk, intermediate risk, and high risk. You should certainly talk to your doctor about screening and about treatment options, including active surveillance, surgery, and radiation. And here's a couple of resources: the American Cancer Society, Zero Prostate, and the Prostate Health Education Network. And that should do it.
Thank you, Dr. Ali.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.